Hello, this is Dr. Mustafa, and today we're going to be discussing vital signs. Today we're learning about vital signs, which are essential indicators of a patient's health. The five vital signs are temperature, pulse, respirations, blood pressure, and pain. These give us important clues about the body's condition and help us recognize changes early. As nurses, we must know the normal ranges, understand how these vary with age, and always measure them accurately. Remember, vital signs are the foundation of patient assessment and are often the very first signs that something is wrong. The body produces heat as a byproduct of metabolism. When metabolism speeds up, such as during exercise or illness, heat production increases. If the body is invaded by pathogens, the temperature rises to increase the basal metabolic rate and help destroy those pathogens. This is why fever is a natural defense mechanism. It's important to connect the dots for patients. Fever isn't the illness itself, but the body's way of fighting infection. One major factor that affects heat production is the thyroid hormone. Increased thyroid hormone raises metabolism, which in turn raises body temperature. Low levels of thyroid hormone slow metabolism, resulting in lower body temperatures. This means patients with thyroid disorders often experience abnormal heat or cold tolerance, and we need to keep that in mind when assessing their vital signs. Other hormones also play a role. Epinephrine, norepinephrine, and testosterone increase metabolism and therefore raise body temperature. Men usually have a higher metabolic rate because of testosterone. Voluntary muscle movement also increases heat production, and shivering can increase heat production up to 5 times the normal amount. Think about patients who are shivering. This is the body's attempt to generate heat and maintain a stable temperature. The hypothalamus acts as the body's thermostat, controlling temperature. When pathogens release pyrogens, the hypothalamus raises the set point, leading to fever, or what we call pyrexia. If the body's temperature drops, the hypothalamus responds with peripheral vasoconstriction and shivering to preserve heat. If the body temperature rises, it responds with vasodilation and sweating to release heat. This balance keeps the body in homeostasis. The body also loses heat in four main ways: radiation, conduction, convection, and evaporation. For example, radiation occurs when heat leaves the skin to the environment. Conduction happens when heat transfers to a cooler surface like cold bedsheet. Convection occurs when air currents move heat away, like a fan blowing, and evaporation is when sweat evaporates, which can result in about 800 milliliters of water loss per day. That's a big reason hydration is so important for patients because it also assists with body temperature regulation. A fever is defined as a temperature above 100.2 degrees Fahrenheit or 37.9 Celsius. Fever occurs when normal regulation mechanisms can't keep up with the body's heat production. Pyrogens such as bacteria trigger this response. The body tries to cool itself through diaphoresis or sweating. It's important to monitor patients closely during fevers because it can stress the heart and other organs, especially in vulnerable populations like children and the elderly. The pulse is created by the heart contracting and pushing blood into the arteries. The sinoatrial node or SA node initiates each beat. Each contraction pushes about 60 to 70 milliliters of blood into the aorta, which is known as the stroke volume. The strength of the pulse depends on the stroke volume. If we multiply stroke volume by heart rate, we get cardiac output, which averages about 5 liters per minute in an adult. We usually assess the pulse by palpation or auscultation. The strength depends on both the force of contractions and the circulation of blood volume. The rate can be affected by factors like fever, pain, hypoxia, anxiety, exercise, or heart disease. While the pulse rate itself doesn't normally change with age, elderly patients are more likely to have dysrhythmias. There are many places to check the pulse. The most common is the radial artery at the wrist. Others include the temporal artery in front of the ear, the carotid artery on the neck, the femoral artery in the groin, the apical pulse at the apex of the heart, the popliteal pulse behind the knee, and the posterior tibial pulse near the ankle. It's important to know all these sites because certain situations like shock or cardiac arrest require specific pulse points for accuracy. Pulse rates can be influenced by age, body build, blood pressure, medications, emotions, blood loss, exercise, temperature, pain, and oxygen levels. For example, pain and fever usually increase the pulse rate, which while blood loss can make the pulse weak and rapid. Understanding these factors helps you interpret pulse changes in context rather than looking at the number alone. When we assess pulse, we look at its rate, rhythm, and volume. In arrhythmias, an arrhythmia means a normal rhythm is broken by irregular beats. We describe pulse strength on a scale. Weak but regular is a 1 plus or plus 1. Strong and regular is a plus 2. Full and bounding is a plus 3. We may also say a pulse is feeble, irregular, thready, or absent. Always document these findings carefully because they provide important clues about circulation and heart function. Respiration is an involuntary automatic function controlled by the respiratory center in the pons and medulla of the brainstem. The drive to breathe is usually triggered by increased carbon dioxide or hydrogen ion concentration in the blood, or by decreased oxygen levels. The major organ of respiration includes the nose, the pharynx, larynx, trachea, bronchi, and lungs. As LPNs, it's important to remember that change in breathing are often one of the earliest signs of patient deterioration. The respiratory center works with feedback mechanism to adjust breathing. Receptors in the carotid arteries monitor carbon dioxide levels and adjust the rate and depth of respirations as needed. Gas exchange in the lung allows oxygen and carbon dioxide to diffuse across capillaries to maintain balance. Any disruption to this process can quickly become life threatening, which is why respiratory assessment is critical. While measuring respirations, we usually count for 30 seconds and multiply by 2. For very ill patients or those with irregular breathing, we must count for a full minute or 60 seconds. If carbon dioxide rises or oxygen drops, the respiratory rate increases. Remember to count respirations without the patient knowing because patients often change their breathing pattern if they are where you are watching or counting. There are several important breathing patterns to recognize. Eupnea is normal breathing. Dyspnea is difficult, labored breathing. Tachypnea means rapid breathing, while bradypnea is slow, shallow breathing. Hyperventilation is both rapid and deep breathing. Kussmaul respirations are rapid, deep, and labored with long exhalations, often seen in diabetic ketoacidosis or DKA. Biot's respirations are irregular with variable apnea, while Cheyne-Stokes involve periods of dyspnea followed by apnea. Recognizing these patterns helps us identify underlying conditions. We may also hear abnormal or noisy respirations. Crackles are non musical popping sounds during inspiration, often from fluid buildup in the lungs. Gurgles, also called low pitched wheezes, are rattling sounds from secretions. Stre- stertor is a snoring sound from airway obstruction. Stridor is a crowing sound on inspiration from upper airway obstruction, common in croup or laryngitis. And wheezes are whistling sounds caused by narrowing airway, often heard in asthma. Documenting and reporting these sounds is vital. It is important for you to know what all of these sounds mean and what causes the different sounds. We will cover these more in depth in the respiratory chapter. A pulse oximeter or pulse ox is a quick, non invasive tool to measure oxygen saturation. It works by determining the presence of hemoglobin bound with oxygen. A probe is placed on a finger, toe, or ear, and it uses light waves to measure oxygen levels in the capillaries. Normal saturation is typically 95% to 100, but always interpret results in the context of the patient's overall condition. Remember, this you will hear this sentence a lot. Always treat the patient, not the numbers. Blood pressure is the force that the blood exerts on the arterial walls during pumping of the heart. It's affected by the condition of the blood vessels, the circulating blood volume, and the cardiac output. Normal changes in blood pressure occur with aging, but abnormal changes can signal serious problems. That's why we check it routinely with every patient. There are two key measurements in blood pressure. Systolic pressure is the force when the heart contracts, and diastolic pressure is the force when the heart relaxes. Blood pressure is influenced by cardiac output and blood volume. If blood volume increases, pressure rises. If blood volume decreases, pressure falls. This is why patients with dehydration or hemorrhage may have dangerously low blood pressure. If blood volume drops too much, the vascular system can't compensate and blood pressure falls. Causes include dehydration, hemorrhage or bleeding, or changes in vasoconstriction and vasodilation. These patients are at risk for shock. Monitoring blood pressure trends over time is often more important than just a single blood pressure reading. The average blood pressure in a healthy young adult is 120 over 80 millimeters of mercury. Anxiety, stress, and fear can all raise blood pressure, so we try to measure in a quiet, relaxed setting. Always support the arm at heart level and use proper cuff size. Consistency is key for accurate measurement. It's important to make sure that your patient is sitting with both feet on the ground on the edge of the bed or a chair, or if they're laying in bed, that the head of the bed is slightly elevated if possible and the arm is at heart level. Crotkoff sounds. When measuring manually, we listen for Crotkoff sounds as the cuff deflates. Phase 1 is the first tapping sound. This is the systolic pressure. Sometimes there's a brief silence called the oscillatory gap. Phase 2 is a swishing sound. Phase 3 is knocking. Phase 4 is muffling. And phase 5 is silence. This is the diastolic pressure. Being able to correctly identify these sounds takes practice but is an essential nursing skill. You will cover all of these sounds and how to correctly measure blood pressure in the lab. Hypertension means blood pressure that is consistently above the normal range. A systolic pressure above 140 millimeters of mercury or a diastolic above 90 millimeters of mercury is considered high. Prolonged hypertension is dangerous because it can cause permanent damage to the brain, kidneys, heart, and eyes. This is why we call hypertension the silent killer. Patients may not feel symptomatic until the damage has already occurred. Hypotension is low blood pressure, usually less than 90 over 60. It can be caused by blood loss, dehydration, or shock. Another common issue is postural hypotension, which is a drop in blood pressure when the patient changes positions, such as from sitting to standing. This can cause dizziness and falls, so it's especially concerning in the elderly. Always check for postural changes if your patient feels lightheaded when standing up. As patients age, their vital signs may change. Older adults lose heat more easily and are at risk for hypothermia due to lower metabolic rate. Their respiratory rate may vary because of reduced lung capacity. Blood vessels become less elastic, so systolic and diastolic pressures may rise with hardening of the arteries. These changes are considered normal, but we still must assess carefully for signs of disease. Normal body temperature ranges between 97.5 and 99.5 degrees Fahrenheit. It's important to know each patient's usual baseline temperature because some people naturally run lower or higher. Temperature also varies depending on the site where it's measured: oral, rectal, axillary, tympanic, or temporal. Rectal temperatures are usually about 1 degrees higher than oral. Axillary temperatures are 1 degrees lower than oral. Tympanic and temporal measures are generally close to core body temperature. Knowing these differences helps you interpret results accurately. Several things can affect temperature reading: time of day, environmental conditions, age, exercise, menstrual cycle or pregnancy, status, stress, illness, and medication. Even something as simple as eating, drinking, or breathing through the mouth can alter results. That's why we must take context into account before drawing conclusions. Hyperthermia is an abnormally high temperature, also called febrile state, or pyrexia. Hypothermia is when the body temperature drops too low. Both are serious conditions that require nursing intervention. Patients at either extreme are at risk for complications, so frequent monitoring is essential. When a patient has a fever, nursing care focuses on cooling and comfort. We can increase fluid intake, lower the room temperature, improve air circulation, and remove excess clothing or blankets. Activity should be minimized to reduce heat production. A sponge bath or cooling blanket may be used, and the provider may order antipyretics such as aspirin or Tylenol, acetaminophen. Always follow physician's orders while using supportive nursing measures. Hypothermia is when the body temperature drops below 95 degrees Fahrenheit. Patients at risk include infants, surgical patients in the operating room, the elderly, and anyone exposed to cold weather or cold water. Hypothermia can be life threatening, so we must intervene quickly with warming blankets, heated IV fluid, or other measures depending on sensitivity. To take an oral temperature, place a thermometer or probe in the sublingual pockets under the tongue. The patient should keep the mouth closed and avoid talking. Always use a plastic sleeve or probe cover for infection control and remove it before reading the result. This method is simple and common, but it requires patient cooperation. For rectal temperature, always provide privacy and drape appropriately. Wear gloves, lubricate the probe, and insert it gently. Hold it in place for 3 to 5 minutes or until the device signals completion. Clean the probe from stem to tip, wipe the buttocks, dispose of supplies properly, and wash your hands. Rectal readings are very accurate but may be uncomfortable or inappropriate in some patients. To take an axillary temperature, place the thermometer in the center of the dry armpit. Ask the patient to hold their arm tightly against the chest. Leave it in place for 3 to 8 minutes or until reading is complete. This site is less accurate, but it's useful when oral or rectal routes are not possible. There are several types of thermometers. Glass thermometers should not be used orally in unconscious, confused, or agitated patients. Glass thermometers are not used very commonly anymore unless you're in a really old doctor's office. I have never seen glass thermometers in the past 8 or 9 years that I've been a nurse. Electronic thermometers are quick and common. Tympanic thermometers measure from the eardrum, and temporal artery thermometers measure across the forehead. There are also disposable single-use thermometers, which are helpful for infection control. These are the same thermometers that you will use with patients who are in isolation. Pain is recognized as the fifth vital sign. The Joint Commission requires that we assess pain routinely. We must ask about the location, intensity, character, frequency, and duration of the pain. Standardized pain scales, such as the 0 to 10 numeric scale or the Wong Baker Face Scale, help patients communicate their pain clearly. Always take pain reports seriously and document carefully. Remember that pain is what the patient tells you it is, and you must trust the patient and chart what they tell you. Finally, you'll see several different kinds of vital sign monitors and devices. Automated monitors are lightweight, portable machines. They're also called nurses on wheels. They're called Dynomaps. They measure blood pressure, heart rate. They have pulse ox, thermometers. You can get a full set of vitals with them. Uh, Results are obtained in less than a minute and displayed digitally. These machines can also store the data so you can refer back to it if you need it, making it easy to track trends. You must remember that you always treat the patient, not the numbers. You always double check. If you're getting a blood pressure on a patient that's 40 over 20, but your patient's sitting on the edge of the bed talking to you, obviously that's not correct. So you need to get a manual blood pressure. Sometimes the machines, the Dynomaps or the machines, the wall-mounted computers won't be able to track a blood pressure or pulse ox. You might need to use some manual devices. Always assess the situation, assess the patient, and use the appropriate monitoring devices.